Hello, and welcome to the Clinical Care Options Oncology podcast. I'm your host, Tim Quill. In this episode, Dr. Keith McCrae from the Taussig Cancer Institute of the Cleveland Clinic, Dr. Nichola Cooper from Hammersmith Hospital, Imperial College in London, and Dr. Rachael Grace from the Dana-Farber Boston Children's Cancer and Blood Disorder Center will be providing expert insights on ITP management and addressing frequently asked questions from a live CCO symposium held during the annual Hematology meeting in December 2021. This episode is part of a larger educational program entitled Advances in Immune Thrombocytopenia, Expert Guidance to Navigate an Evolving Therapeutic Landscape. For more information on the experts, along with a link to the complete program, including an on-demand webcast, a downloadable slide set, and a clinical thought commentary, please visit the show notes for this episode. Now let's get started and hear what the experts have to say on this important topic.
Good morning, everyone, and welcome to this session on Advances in Immune Thrombocytopenia, Expert Guidance to Navigate an Evolving Therapeutic Landscape. My name is Keith McCrae. I'm from Cleveland Clinic, Director of Benign Hematology, and our other faculty are Rachael Grace, who's an Associate Professor of Pediatrics at Harvard Medical School, Dana-Farber Boston Children's Cancer and Blood Disorder Center, and Nichola Cooper, who's an Honorary Consultant Hematologist at Hammersmith Hospital and Imperial College in London. And at this point, I'm going to turn the microphone over to Dr. Cooper, who will be talking to us from London. And the title of her talk is Initial Management of ITP, Diagnosis and Treatment Considerations. Dr. Cooper?
I'm going to talk most about adult ITP because Dr. Grace will talk about pediatric ITP afterwards. But I think some of the aspects are really important to consider for both pediatric and adult ITP, and we shouldn't necessarily consider them two different entities. And I think when we're thinking about first-line treatment for any patient with ITP, we need to really remember what our aims are and whether we consider that there are different types of ITP patients, not just age-related, but what kind of ITP they have. And important to note that although ITP is considered a bleeding disorder, actually significant bleeding is really uncommon at any age. Health-related quality of life impairment, including fatigue, is often more significant when we look at some of that data. I think finally, something we're not going to touch on today, but to remember that actually thrombosis, although rare, can be devastating. And certainly in a patient with thrombocytopenia, thrombosis is a significant event. And at the moment, we treat children and adults with ITP very differently, but perhaps we shouldn't be quite doing so, but actually defining patients better on the type of patients they are. So defining a patient as to whether they're a bleeding type, whether there's a health-related quality of life type, or thrombosis. And I think one of the things we're really understanding that ITP is not just one disease, but there are a number of different features, and we should be thinking about those features really rather than just treating each patient the same. At the moment, these are one of our guidelines. So the 2019 published ASH guidelines for adults with newly diagnosed ITP recommends that patients with a platelet count less than 30 who are asymptomatic or who have minor mucocutaneous bleeding, the guideline panel suggests giving corticosteroids rather than observation. That's the opposite of what's advised for pediatrics. ASH guidelines, however, recommends against a prolonged course of prednisolone in favour of a short course and recommends either prednisolone or dexamethasone as corticosteroid for initial therapy. I think one really important point to take home is to not give long courses of steroids to patients. And certainly we know there's very little evidence that this is changes the course of the disease and certainly is the cause of considerable morbidity, mortality in patients with ITP. So in summary, first-line treatment does continue to be steroids, although these are poorly tolerated and there's little evidence that they alter the course of the disease. IVIG I've not spoken about today, but it is expensive. It's a scarce resource and should be used with careful thought. Rituximab, MMF, and thrombopoietin receptor agonists may improve response rates, may reduce the steroid impact. However, in the context of COVID-19 and vaccine responses, I think immunosuppression really needs to be used with caution. Whether long-term remissions alter with combined treatment really needs further study.
Thank you. That was a great talk. Really enjoyed that. Let's get back to how we treat patients and how we treat patients who fail initial therapy. But basically, ITP involves a lot of patient choice because very few of these drugs we use have been studied in randomized manners compared to each other. We do have randomized trials, but they're all with placebo, mostly with TPO-RAs, and we don't really have head-to-head comparisons. So in this algorithm, it's suggested that patients be divided into early ITP, 3 to 12 months, persistent ITP, or chronic ITP beyond 12 months. And the primary treatment options in this group are as shown here, rituximab or TPO-RA, and each of them have characteristics in terms of treatment and expectations. So for example, if the patient places a high value on achieving a durable response, but doesn't mind staying on a medication, TPO-RAs are the way to go. Now, if the patient wants to take their shot at getting treated with something and going into a long-term remission, rituximab might be better. And since TPO-RAs play such an incredibly important role in the management of ITP, I just wanted to show this as a review. Most of you are familiar with this, but early responses compared to splenectomy, TPO-RAs, rituximab, sustained responses quite high with TPO-RAs, probably even higher than splenectomy. Rituximab patients do have sustained responses, but it's generally in the 20 to 25% range. Now, one thing we've learned over the last 10 or 12 or more years, actually, since TPO-RAs first appeared on the market, is that they're really safe to use over a long period of time in general. Over these long duration periods, we've seen no new side effects emerge. We've seen no new or increased incidence of myelofibrosis, and they seem to be really quite safe. And most importantly, tachyphylaxis or resistance to these drugs is very uncommon. So this is all good news for these agents. I want to move to some newer agents, and fostamatinib is not brand new, but it's been there for a few years now. And fostamatinib is an inhibitor of SYK, spleen tyrosine kinase. This is an important signaling pathway that leads to inflammatory responses, NF-kappa B activation with inflammatory cytokine, and so forth. And this may actually be one of the things that contributes to some of the fatigue in patients with ITP. So an initial report of fostamatinib, responses seem to be less than those of other agents, but this was in a very difficult population, multiply treated with fifth-line or more treatments in many patients. And in a subsequent analysis of the data, breaking down responses by the line of therapies the patients had treated with before this, it was found that those who were treated early in the course of therapy did much better than those treated late in the course of therapy. Admittedly, the ASH panel did not recommend that because, in fairness, there isn't a lot of data, but there was some dissent on the ASH guideline committee concerning this. Now, another new target for which there's several drugs in clinical trials is this neonatal FC receptor, or FcRn. So you're probably familiar with FC receptors on macrophages that internalize antigen-antibody complexes. I've talked about these. This is a different kind of FC receptor. It's called neonatal because it was first found in the placenta, and it helps to transfer IgG across the placenta. But it's really in almost all organs in the body, and is particularly important in the blood. It's highly expressed on endothelial cells as well as on monocytes. And what it does, basically it endocytoses plasma proteins. Now, these endosomes undergo a complex sorting procedure, and basically those proteins that are not actually bound to FcRn are shuttled to the lysosome and are degraded. But those that are bound to FcRn are recycled to the surface. And then when they hit the neutral pH upon exocytosis, IgG dissociates and goes back into the blood. So this basically recycles IgG, including IgG antiplatelet antibodies. So if there's a way we could block this, it would be kind of like doing plasma exchange chemically. And so there's several drugs that have been developed for this. Now, another target here that's involved very importantly in B-cell development and immunology is Bruton's tyrosine kinase. Most of you are probably familiar with ibrutinib, which is a BTK inhibitor. Ibrutinib has been used in ITP, but the problem with ibrutinib is that it can cause bleeding through inhibition of platelet function, and it also can cause atrial fibrillation through interactions with PI3 kinase. Finally, I'd like to talk about sutimlimab for just a moment. This is a very interesting drug. It's an anti-C1s antibody, and it blocks activation of the classical complement pathway. I'll spare showing you that pathway today, but C1 is the most upstream protein in the classical complement pathway. This drug is being developed for cold agglutinin disease in particular, where it seems to have quite a bit of activity. But in this study that was again reported at ASH in 2019, in a small number of patients, it was tried in ITP. And I will mention that there's some other data from Haniel Semkeri and David Cooter on complement and ITP. Actually, complement and ITP was first described about 30 years ago and then ignored, but it may play an important role. So just to summarize where I am here, new advances in ITP. ITP management has improved dramatically. We need more mechanistic studies. We need targeted therapies that modulate specific pathways. We still lack agents that reliably reduce long-term remissions of adult ITP. And my plea to clinical trials is that all ITP trials include a translational research component where we save plasma cells and so forth on treated patients so we can really learn what these drugs do. And I'm going to turn this over to Dr. Grace.
I'm going to be talking about management of thrombocytopenia in special populations with ITP and thrombocytopenias with other etiologies. First, going to be talking about the very relevant topic of vaccines and ITP. As an idiopathic ITP, vaccines are hypothesized to lead to ITP through molecular mimicry, epitope spreading, and polyclonal activation, as well as related to vaccine adjuvants. And although ITP has been reported after many and maybe even every vaccine, the MMR vaccine is the only vaccine with a reliable relationship. The incidence is likely lower than was originally reported and closer to 1 in 40,000 doses of the MMR vaccine, which is significantly lower than the reported incidence of ITP after the viruses that the vaccine protect against. So what do we know about the COVID-19 vaccines and new onset ITP? This association is challenging to study because ITP is a diagnosis of exclusion. So in addition to other etiologies, thrombocytopenia after COVID vaccine must be differentiated from vaccine-induced thrombotic thrombocytopenia, as well as previously undiagnosed ITP with a flare after the vaccine. ITP has been reported after mRNA vaccines with an incidence of about 1 in a million, and the AstraZeneca vaccine with an incidence of about 1 in 100,000. And both of these incidences are lower than the incidence of ITP in general. And so if these are vaccine associated, they're rare, and they might be the first example of a killed virus vaccine associated with the development of new ITP in adults. At this time, the association between SARS-CoV-2 vaccines and the development of new ITP isn't clear. And if there is a causal relationship, it's clearly rare, and the risk appears to be far less than the risks associated with COVID infection. Is it safe then to vaccinate patients with ITP against COVID? In young patients with MMR-associated new onset ITP, there doesn't seem to be a recurrence with the second MMR dose. However, transient thrombocytopenia after vaccination in patients with ITP with other vaccines, for example, the annual influenza vaccine, is a well-known phenomenon among hematologists that isn't well reported in the literature. In the cohorts that have been described with a dip in the platelet count after the COVID vaccine, most have not had serious bleeding reported. With this information, it's generally recommended to have a shared decision-making approach to the COVID vaccines in patients with ITP, but overall, the recommendation is to proceed with vaccination based on available data. You can consider obtaining a pre-vaccine platelet count and then platelet counts within the week or so after each dose of the COVID vaccine, particularly in patients who prefer monitoring or in those who have bleeding symptoms after the vaccine. If a patient has a dip in the platelet count with the first vaccine, there won't necessarily be a drop with the second vaccine or the booster dose, but this isn't exactly clear either. Guidance with the subsequent vaccines after experiencing a drop in the platelet count after the first vaccine needs an individualized approach based on risk-benefit. Up to 15 to 20% of patients with active ITP may experience worsening thrombocytopenia after the COVID vaccines. The risk of thrombocytopenia and other symptoms is much higher with actual COVID infection, and therefore vaccination is recommended with monitoring of the platelet counts in specific populations. Consideration and testing for primary immune dysregulatory disorders may lead to novel ITP treatment approaches. The approach to management of pediatric ITP is different than adult ITP. Many children with skin symptoms only can be actively observed up until a remission, whereas other children will have symptoms requiring first and second line treatments. Thrombopoietin receptor agonists aren't just for ITP and may represent a treatment option for patients with inherited platelet disorders, chronic liver disease undergoing procedures, and chemotherapy-induced thrombocytopenia.
Rachel, let me just ask you a question. So I don't know if your institution mandates COVID vaccines or not, but let's just say they do. And you have a colleague come to you who said, I had ITP like 4 years ago and I got treated and it took about a year, but I'm sort of been in remission since then. Will you give me a medical exemption? What's your answer to that individual? Because I had somebody do this to me. It wasn't ITP, it was a different response to a flu vaccine. But this individual didn't want to get the COVID vaccine and he wanted help with getting an exemption. But how would you, or Dr. Cooper, how would you respond to that individual? It's one of your colleagues.
I would be very reluctant to exempt anyone from the COVID vaccines. And I think while there's concern about worsening thrombocytopenia in someone who continues to have ITP, I guess that's a question for this person about whether they're in a real remission, true remission, not splenectomized, normal platelet counts now for years. I would think they would be in a remission and not be at risk for that transient thrombocytopenia. But even if they were at risk for the transient thrombocytopenia, having COVID infection comes with much more risk than the risk of vaccine. So it would be hard to argue that the risk is such that you would want to exempt somebody from getting the vaccine. I think where you could raise the question is if somebody had the first vaccine or the first and second vaccine and we're considering a booster or something like that, and had a dip in the platelet count that was clinically important, led to treatment or led to increased treatment or led to bleeding, I think then there needs to be some consideration for what the patient prefers. But I think without having received it yet, that it would be hard to argue that it would be worse to be vaccinated and better to get the actual infection, which we know comes with many more risks, including thrombocytopenia.
Okay.
I agree. I would not feel that I could give an exemption. I think you can discuss it with them, and I think it's really important to document the advice that you give as well. You can't guarantee that there's not going to be a relapse. But again, as Dr. Grace is saying, I think if you the risk of ITP with COVID may be just the same as with vaccine. The COVID comes with all of the other problems that the vaccine doesn't.
What's interesting in pediatrics too is that we occasionally, but not often, I think, have lots of conversations about the annual influenza vaccine. Are there vaccines? Some families do ask about that, but other families just go for it, with having active ITP. But yet with this vaccine, there's a lot more discussion and obviously a lot more literature about what happens with the platelet count. It hasn't been well reported with the other vaccines. And so the attention to that previously has been much, much different.
Okay.
So my question is, can any of you comment on a link between cytokines and fatigue in ITP? I heard that the IL-6, which sometimes associated with the fatigue. And I know that in COVID vaccinations, it's a very common observation that there is a severe fatigue. Sometimes I wonder if anyone correlated cytokines there with that observation.
That's a great question. The question was, I don't know if everybody heard it well, that basically about fatigue and ITP, fatigue after vaccination. I think it was probably me that speculated that this may be related to cytokines. That is what is often written, though in my understanding from what I've seen, there's clearly abnormalities of cytokines in ITP and other inflammatory diseases, whether there is some elevations in plasma in some patients, but they're not striking. So could it be the similar mechanisms with vaccinations and ITP? And I'll broaden that and say any sort of autoimmune disorder. I see a lot of antiphospholipid antibody patients who have very severe fatigue. We actually measured some cytokines in some of those people. Haven't really looked directly in ITP, but in APS, we found some strikingly high elevations of several cytokines. So it certainly could be a similar mechanism. I think there's probably an overlap in a lot of these disorders. Any thoughts from the rest of the panel?
I think like every other study you do with ITP, it's a heterogeneous disease. And I think it's something we need to tease out. There are different types of patients probably. We have done some cytokine work and some fatigue work. We see nothing. It's not published. And I think that, there has been some talk about whether IL-6 is high in patients with fatigue, but I don't think there's any good evidence that it is cytokine mediated. And I think the other problem with fatigue is it's very difficult to diagnose. The questionnaires are not perfect for that. Is depression a problem? Anxiety, all of those things impact on fatigue. So those studies are not easy to do, I think.
This goes back to one of my summary points that I think it would be wonderful if every ITP study collected samples from patients at different time points. And whether they're federally funded or pharma funded, it is extra money. It is extra cost to do that, and extra hassle. But, having those samples available and large numbers of samples, I think would help us learn so much more about ITP itself, as well as of responses to new treatments and pathways involved in ITP. So the question is, in some of the newer drugs that I discussed, have there been any studies in children of these agents? And I don't think there have been that I have come across. Rachel, have you seen anything in pediatrics in some of these newer approaches?
Pediatrics is often a little bit behind where things are approved for adults. So there's currently an open trial of avatrombopag for children with ITP. So that is obviously approved for ITP in adults, but it is not approved younger than the age of 18 in the US. So that trial is currently open and enrolling. And then the BTK trial is aged down to the adolescent ages. So not involving the younger children, but the kind of adolescent age patients can enroll in that trial. So there are a few of the newer drugs that are being studied in the pediatric or teenager population, but several or many, I would say, that are being studied only in adults. And for example, fostamatinib is only approved for adults and isn't being studied in children. So there are clear differences in terms of what's available to children, even in clinical trials, and for sure in terms of what's approved.
I think we have time for one more question.
Keith, you presented some interesting data with the BTK in it from an efficacy standpoint. Is there any concern in terms of utilizing ITP from a safety perspective, similar to the CLL experience, and specifically with the ibrutinib and like AFib? Are those things being looked at here?
Yeah, no, they're being looked at. I mean, I think that the general thought is that the specificity of the newer agent is so much higher than the ibrutinib. And of course, with so many kinases, there's always some off kinase effect. But there doesn't seem, for example, the AFib, seems from what I've seen to be possibly related to PI3 kinase, and the rilzabrutinib doesn't hit that, for example. So it doesn't affect platelet aggregation, whereas ibrutinib does. So far, I mean, they're looking at that, but I think it should be a go. So I think we're about wrap up. I think I really enjoyed this. I hope everybody thinks this is worthwhile and has learned some things. Thank you.
Thank you very much, Dr. McCrae, Dr. Cooper, and Dr. Grace, and thanks to you, the listeners, for joining us. As a reminder, to view the full program, Advances in Immune Thrombocytopenia, Expert Guidance to Navigate an Evolving Therapeutic Landscape, please click on the link in the show notes. As always, thanks for listening.